Welcome back to the Deep Dive. Today is February 4th, 2026. If you are listening to this, chances are you are standing in a pair of scrubs, maybe grabbing a stale coffee before the red phone rings.
Or you're on your commute in, mentally prepping for a night shift in Resus.
Exactly, which is why we're doing something a bit different today.
Usually we take a concept and, we explore it broadly. Today, this is a high-level clinical briefing. It's specifically for the emergency medicine clinician.
We are stripping away the fluff. The mission for this deep dive is to synthesize the current architecture, the assessment protocols, and the management strategies for major trauma in the NHS.
And we're pulling from the bedrock of your practice. Nice guidelines like NG39, NG232, the BOAST standards, all of it.
This is about the system as it functions right now, isn't it? Not the textbook version?
Precisely. This is actionable intelligence you can use at the bedside tonight.
Okay, so let's start with the bottom line up front. An ST4, a new consultant, is walking onto the shop floor. What's the executive summary of the UK trauma landscape?
The summary is this. The system has successfully moved from a fragmented model to a tiered major trauma clinical network. The whole philosophy is right patient, right place, right time.
But there's a catch.
There is a catch. The data reveals a critical friction point, and it affects everyone listening.
And that friction is it capacity?
It's absolutely capacity. We know that bypassing local hospitals to get a patient to a major trauma center, an MTC, improves survival. That's not up for debate.
Right.
But MTCs are facing a massive bottleneck, often capped at 75 trauma beds. This leads to a lot of severe trauma being managed in trauma units.
And what does the data say about that?
And here's the scary stat. Direct-to-trauma unit pathways for patients with an injury severity score over 15, they carry significantly higher mortality risks.
Wow. That is a sobering reality to open with. It really implies that if you're in a TU or even a local emergency hospital, you're not just a pass-through.
You're the safety net. The toolkit we're discussing today, the CABCDE approach, all of it is vital regardless of where you work. The physiology doesn't care about your postcode.
So let's clarify that architecture then. We have MTCs, TUs, and LEHs. Operationally, what's the difference?
It really comes down to two things, specialist capability and the 24/7 clock, and MTC is the regional hub.
Okay.
To hold that designation, you need consultant-led teams physically in the building, 24/7, immediate access to neurosurgery, vascular, plastics, all the eleologies. They are built for an ISS greater than 15.
And the trauma unit, the TU, where does that fit in?
The TU is for less severe cases, so an ISS under 15, or for stabilizing patients who are just too unstable to travel any further.
And the requirement there?
The requirement is a consultant-led team, or at least a senior registrar with a consultant who can get there within 30 minutes, and crucially, 204/7 access to a whole-body CT.
Right, and then the LEH, the local emergency hospital.
That's your general A&E. Their role in major trauma is simple. Treat and transfer. Do not sit on these patients. Basic stabilization, maybe secure an airway, and get them out.
You mentioned that direct-to-TU mortality risk. That puts a huge amount of pressure on the pre-hospital triage. How are paramedics making that call?
They use what's called pathfinder logic, and the system is designed to deliberately accept a degree of over-triage.
So better to send a minor injury to the MTC
than to miss a major one and send them to a local unit where they might deteriorate.
Absolutely.
So what are the specific triggers? What are they looking for?
It's a triad: physiology, anatomy, and mechanism. Physiology is all about the numbers. Respiratory rate under 10 or over 29, systolic BP under 90, or a GCS motor score of 4 or less.
Those are heart stops.
Heart stops, they go straight to the MTC.
And anatomy.
That's the obvious stuff. Penetrating torso injuries, 2 or more long bone fractures, amputation, things you can see.
Okay, and mechanism. This is where it gets a bit grayer, isn't it? It is. This is about high energy transfer, so ejection from a vehicle, falls from more than 3 meters, that kind of thing. But, and this is a big but, we have to talk about where this fails.
Let me guess. The elderly.
Exactly. Silver trauma. Recent studies, like the MET study, showed these traditional criteria were consistently missing major trauma in older patients.
So the classic red flags just don't fly for an 80-year-old.
Not at all. If you rely only on mechanism for the elderly, you will under-triage them. The tools are evolving now, relying more on, good old clinical judgment.
Okay, let's move inside the doors. The red phone's rung. The patient is in the bay. We all learn ABCDE, but in trauma, we stick a C on the front. Talk about that prioritization.
C is for catastrophic hemorrhage. And the logic is, well, it's brutally simple. You can intubate a patient perfectly, secure the best airway in the world.
But if they exsanguinate while you're doing it, they're still dead.
They're still dead. Before you even look at the airway, you clamp the bleed.
In the field, that's tourniquets. In the hospital.
It's immediate activation of the major hemorrhage protocol. And you are controlling the source. Direct pressure, pelvic binders. If you even suspect a pelvic fracture, that binder goes on immediately.
Okay, so bleeding is temporarily controlled. Now we're at A airway and C spine. Nice NG39 has some pretty strict timelines here.
It does. If the airway is compromised, so GCS less than 8 or they can't maintain it, the standard is rapid sequence induction, RSI. And the target is to get this done within 45 minutes of the initial 999 call.
That's an incredibly tight window.
It's aggressive. It basically means the decision to intubate has to be made the second they hit the door. If you can't get RSI right away, use a supraglottic device as a bridge.
But the non-negotiable part is the C-spine.
Always. Manual inline stabilization. You do not move that neck. We assume a C-spine fracture until it's proven otherwise.
Okay, moving to B, breathing. We're hunting for the immediate life threats.
Tension pneumothorax, open pneumothorax, massive hemothorax. And the biggest pitfall here for any clinician is waiting.
Waiting for imaging.
Waiting for the chest x-ray. If a patient is hypoxic, accent breath sounds, tracheal deviation, that is a clinical diagnosis of a tension pneumothorax. NICE is crystal clear. You decompress now.
Needle or finger? That debate seems to have settled.
I think it has. The guidance has really shifted towards a definitive finger thoracostomy in the trauma bay. Needles can fail, they can kink. A finger thoracostomy in the triangle of safety ensures you're actually in the pleural space.
Got it. Now, C circulation. This feels like the area that's seen the most radical change in the last decade or so.
Oh, absolutely. We are not pumping people full of saline anymore. That is a relic. If you see someone hanging a bag of 0.9% saline for a trauma patient, please stop them.
So the paradigm is now damage control resuscitation.
Yeah.
And what was the other term?
Permissive hypotension.
Right. Unpack that for us, because seeing a systolic of 80 on the monitor feels wrong.
It feels very wrong, but it's necessary. If you normalize their blood pressure before the surgeons have control, you risk popping the clot. You just blow out the body's natural hemostasis.
So you accept a lower pressure.
We accept a palpable radial pulse or a systolic around 80-90. It maintains perfusion without restarting the bleed.
Is there an exception to that rule?
Yes, a big one. Traumatic brain injury. If TBI is the main injury, you cannot allow hypotension. The brain needs that perfusion pressure.
So you have to drive the BP up.
To a systolic of at least 110. It's a nightmare scenario in a polytrauma patient with, say, a head injury and a ruptured spleen. It takes senior decision-making right there at the bedside.
Let's talk fluids. Why are crystalloids so bad?
They induce the lethal triad: acidosis, hypothermia, and coagulopathy. Saline is acidic, it's cold, and it dilutes what few clotting factors you have left.
So you go straight to blood products.
Straight to blood. Aiming for a 1-to-1 ratio of plasma to red blood cells, you have to replace like with like.
MTXA.
Tranexamic acid, 1 gram as soon as possible. But the key here is the timeline. The absolute cutoff is 3 hours from injury.
What happens after 3 hours?
The evidence from CRH2 suggests giving it after 3 hours actually increases mortality. It causes thrombotic events, so you have to check the clock. If the injury was 4 hours ago, do not give it.
Got it. D for disability.
GCS and pupils. And always, always glucose. A hypoglycemic patient can look exactly like a TBI patient. It's an easy fix you don't want to miss.
And finally, E for exposure.
Strip them, find the injuries, check their back, but then cover them up immediately. Hypothermia kills the coagulation cascade. A cold trauma patient is a bleeding trauma patient. Get the bear hugger on.
Okay, let's jump to investigations. The primary survey is done. We need to see inside. Whole body CT is the gold standard, right?
For adults with blunt polytrauma, yes. The protocol is a vertex to toes scanogram, then a vertex to mid-thigh CT.
And there's a key practical tip here about patient movement.
Yes. Do not reposition the patient. You slide them across on the scoop. I've seen people try to straighten the leg to get a better picture, and all you do is displace a pelvic fracture and restart the bleeding.
And this doesn't apply to kids.
No. Absolutely not. The radiation risk is too significant. Use clinical judgment and you scan only what is necessary.
What about head injuries? Nice NG232 has the 1 hour rule.
Right. Any patient with a GCS under 13, a suspected open skull fracture, or any focal neurology, they need a scan and a report within 60 minutes of arrival.
And the big one is anticoagulants.
The anticoagulant rule, yes. With so many people on DOACs or warfarin, if they have a head injury, they need a CT within 8 hours.
Look.
Even if their GCS is 15 and they say they feel fine, the risk of a slow creeping subdural is just too high.
Let's talk C-spine clearance. When does the collar come off?
We use the Canadian C-spine rule. It's a hierarchy. First, any high-risk factors. Are they over 65? Dangerous mechanism? Paresthesia in the limbs? If yes, they get a scan, period.
And if no high-risk factors?
Then you look for low-risk factors. Simple rear-end shunt, sitting comfortably, ambulatory. If yes, then you can do the functional test.
Which is?
Ask them to rotate their neck 45 degrees left and right. If they can do that without pain, the collar comes off. If they can't, they get a CT.
And while we're on spines, longboards.
For extrication only, if a patient arrives on a rigid board, get them off it immediately. The pressure sore risk is huge. Skin, scoop, surface. That's the mantra.
Okay, let's pivot to complex management. Specifically orthoplastics. Boast 4 gives us the blueprint here. What are the key jobs for the ED doc?
2 things. Antibiotics and the 1 photo rule. 4 of the antibiotics must be given within 1 hour of injury. That is critical.
And the 1 photo rule.
When you assess the wound, you remove gross contamination, you photograph it once, and then you seal it.
Why only once?
Because everyone wants to have a look, don't they? The junior, the reg, the consultant. Every time you open that dressing, you're introducing hospital bacteria. So 1 photo, upload it, seal the wound. No mini washouts in the bay.
We touched on this earlier, but let's properly dive into silver trauma.
The whole demographic has shifted. The terrifying thing is that their physiology lies to you. We call it hidden shock.
Give us an example.
Okay, take an 82-year-old on bisoprolol. She falls. She comes in with a heart rate of 80 and a BP of 110. On the monitor, she looks fine.
Most people would be reassured by that.
Exactly. But the beta blocker means she physically cannot mount a tachycardia. And if her baseline systolic is normally 170, a BP of a 110 is profound hypotension for her. She is in shock, but the machine won't tell you.
So systolic of 110 in an older trauma patient is a massive red flag.
It should be treated as shock until proven otherwise, and never dismiss the mechanism. A fall from less than 2 meters is the leading cause of major trauma in this group.
And you have to screen for other things too, right?
Absolutely. Use the clinical frailty scale and use the 4AT tool to check for delirium. Sometimes a quiet hypoactive delirium is the only sign of a head injury or significant pain in a patient with dementia.
Another thing to watch for is compartment syndrome.
The absolute hallmark is pain out of proportion to the injury, and specifically pain on passive stretch. If you gently extend their toe and they scream, that's it, don't wait for loss of pulses, that's a pre-amputation sign.
Let's wrap the clinical side with governance. It sounds dry, but it drives everything. We used to talk about TARN all the time.
Yes, the Trauma Audit and Research Network. That's now transitioned to the National Major Trauma Registry, or NMTR, and it is mandatory.
And this all links to the best practice tariff, the money.
It does. For the Level 2 tariff, the targets are rigorous. A consultant must review the patient within 5 minutes of arrival, TXA within 3 hours. And for the elderly, a frailty assessment must be recorded.
So that's why the scribe is always asking, what time did the consultant arrive?
It's not just bureaucracy. It pays for the system that saves lives. It ensures senior decision makers are there when it counts.
And there's also the rehab prescription.
Yes, it's not over when they leave Resus.
No.
That prescription, documenting the plan for their recovery, has to be done within 48 hours.
So we've covered the whole journey, from the roadside all the way up to the ward. What's the big overarching takeaway?
The takeaway is that the network is a single organism. And the protocols, nice, boast, there's a nervous system connecting it all, but that organism is under a huge amount of stress.
And we're back to capacity, right where we started.
We are. The MTCs are full. Silver trauma is exploding. And we know that managing severe trauma in a TU carries higher mortality.
So here's the provocative thought to leave everyone with. If we can't physically move every severe trauma patient to an MTC because the beds just aren't there, what happens then? How does the role of the trauma unit doctor need to change?
I think we're reaching a point where the stabilize and ship model isn't enough. The TU team might need to become experts in managing a level of complexity that was previously just for the MTC.
That survival gap has to be closed.
It has to be closed. And given the bed crisis, it might have to be closed locally.
That's a huge challenge for everyone working in a district general hospital today. It means your skills need to be sharper than ever.
Absolutely.
Check your local massive hemorrhage protocol. Know where the packs are before you need them.
Right patient, right place, right time.
Thanks for listening to this deep dive. Good luck on your next shift.